So good afternoon and welcome to the National Breast Cancer Coalition's Project Lead Advanced Topic Session. My name is Michele Atlan and I am the Chief Programs Officer at NBCC. We're pleased that you could join us today and we look forward to sharing or participating in a very engaging presentation and discussion about checkpoint inhibitors. So before we begin, let me just say a few words about the webinar and provide some logistical details. First, today's webinar is being recorded and the program will be archived and a link will be available after the presentation. You've also been automatically muted to limit background noise. Each of the speakers that we will be featuring today will give their presentation, after which all three will engage in a moderated discussion. Now, I'd like to introduce our moderator, Ivis Sempoya. Ivis is a Senior Director of Programs at Share Cancer Support and a more than 40-year not-for-profit that helps women and their friends and families deal with breast and ovarian cancer through support, education, and advocacy opportunities. She is a two-time breast cancer survivor who was misdiagnosed for 18 months as a young woman with two young boys more than 25 years ago. Ivis represents Share on the board of the National Breast Cancer Coalition. Ivis, I'd like to turn it over to you.
Thank you for that introduction, Michele. I'm glad to be here. But before we begin today's presentation, please join me in remembering an advocate we lost this year. Chiara Alice D'Agostino. She did not miss many breast cancer meetings and events over the past few years. She was certainly a presence, a dancer, model, advocate, and many other things. She loved studying and teaching Italian, and in both college and graduate school, she spent a full year studying abroad in Florence. Shortly after completing her master's degree at age 43, Chiara was diagnosed with triple-negative breast cancer. Within 2 years of her initial diagnosis, she became metastatic to the lungs, lymph nodes, and sternum. She began writing about her experiences on her award-winning blog, Beauty Through the Beast, where she offered an uncensored account of her battle against cancer. After her double mastectomy, she walked the runway of New York Fashion Week for the fashion brand Anna Ono for their mastectomy lingerie line and began a career in modeling, including participating in a Dove campaign. She became a breast cancer advocate by volunteering at Share for our helpline and our metastatic programs. As a volunteer for Share, she attended support groups and educational programs. She graduated from NBCC's Project Lead and attended several advocacy summits in DC. As an advocate, she spoke at many meetings. At Cancer Care, AACR, and at Share, she was part of a triple-negative breast cancer clinical patient advisory board and lobbied Congress with NBCC for the Department of Defense Breast Cancer Research Program and the Metastatic Breast Cancer Access to Care Act. As an outspoken breast cancer advocate, she was fearless in spreading awareness of metastatic breast cancer. She was featured in Oprah magazine, interviewed by CBS Radio, included on a Today Show segment on a breast cancer show, and she was also involved in numerous other publications, including the Wall Street Journal, Huffington Post, and New Jersey Monthly. After taking part in several clinical trials through her diagnoses, Chiara died August 4th, 2020, at the young age of 48 of metastatic triple-negative breast cancer. Her dedication to educate and do more for those with metastatic breast cancer led her to donating her body to science for further research. It was her hope to make a difference for the treatment and lives of those dealing with metastatic breast cancer. Please join me in a moment of silence to remember her. Thank you. I am now honored to introduce our speakers for this afternoon's presentation. Dr. Kim Lyerly is the George Barth Geller Professor of Cancer Research, Professor of Surgery, Pathology, and Immunology at Duke University in North Carolina. Dr. Lyerly is a highly sought-after consultant and advisor and has served on the Cancer Center's external advisory boards for MD Anderson, University of Michigan, University of Chicago, University of Alabama, University of Arizona, Boston University, and Purdue. He is an internationally recognized expert in cancer therapy and immunotherapy and has published over 300 scientific articles and book chapters and has edited 10 textbooks. Dr. Sarah Hurvitz is a professor at the David Geffen School of Medicine at UCLA, medical director of the Johnson Comprehensive Cancer Center Clinical Research Unit, co-director of the Santa Monica UCLA Outpatient Oncology Practices, and director of the Breast Cancer Clinical Trials Program at UCLA. She specializes in the treatment of women with breast cancer and is involved in designing, implementing, and leading national and international clinical trials to test new targeted therapies. She is board certified in internal medicine and medical oncology. She currently leads the Translation Oncology Research Laboratory at UCLA in the preclinical evaluation of novel breast cancer targets. Michele Atlan is a 7-year breast cancer survivor and a patient and research advocate. In 2015, she graduated from Project Lead. She now participates as a frequent Project Lead mentor to help her fellow patient advocates understand the science of breast cancer. Currently serving as president of the Breast Cancer Care and Research Fund in Los Angeles, Michele has participated as a consumer reviewer for the Department of Defense Breast Cancer Research Program and is a member of the California Breast Cancer Research Program's Advisory Council. Since 2018, she has been an alternate board member of NBCC and participated in its 2020 Artemis Project Research think tank. I would like now to turn it over to Dr. Lyerly.
Thank you, Ivis, and thank you to those who are joining this webcast. I would also like to acknowledge the NBCC and all of those who are participating in the San Antonio meeting. Of course, this year we're all virtual, but it's been a great event, and I know many people miss the in-person contact with the colleagues and friends. My job this afternoon is to spend some time talking about immune checkpoint blockade and breast cancer therapy, and Sarah will be highlighting some of the clinical research and the clinical results from that research a little bit later. But what I thought I would do is spend some time talking about the basic biology that has led us to use immune checkpoint inhibitors in breast cancer. So let's start by trying to understand how the immune system recognizes breast cancer cells. And although many of us are familiar with antibody-based therapies, such as the drug Herceptin or other antibodies targeting HER2, the emerging role of immunotherapy is based on another member of the immune system, the T cell or T lymphocytes that can be either cytotoxic or helper, as shown in this cartoon. On your left, you see a cytotoxic T cell.
Dr. Lyerly, we don't see your slides.
Oh. Hmm. You see, are you able to see those slides?
Not yet. I think maybe try resharing. There we go. There we go. Thank you.
Thanks for the feedback. Always helpful. So on this slide, on your left, you see the role of the cytotoxic T cell that recognizes, in this case, an antigen on a tumor cell. And what's important here is that the cytotoxic T cells, they actually recognize a small peptide fragment from proteins that are degraded within the cell, shown in the gray zone. A virus or a tumor antigen is processed and then assembled in a complex with the MHC molecules that are then presented. On the very right side is a cartoon showing a peptide molecule, and again, it's kind of like a floppy 9 or 10 amino acid hot dog, if you will, and it's in a hot dog bun. That's the MHC class 1. The helper cells are also a component of the T cell immune system, and these cells tend not to be directly cytolytic, but they produce growth factors and other things that help expand the killer or cytotoxic T cells. And they also recognize these peptide epitopes. The epitopes recognized by helper cells tend to be a little bit longer, but again, the key element here is that these are peptides that are present. These peptides are present in all cancer cells, but the reason your body recognizes them is that there may be mutations in these peptides, and it's interesting that the mutations are sufficiently different that the immune system recognizes them. If you think about things like 9-digit numbers like your social security number, you understand that the power of being able to detect a single digit aberration in a social security number leaves the body with the ability to detect self and not self. And this fundamental biology, the T cell recognition, is the basis for immune checkpoint therapy working today. How do we know that these T cells can recognize a tumor, and how do we know that they can be effective? Well, unfortunately, today it's not so widespread and widely accepted that it functions effectively. But this is an example in which a highly sophisticated laboratory at the National Cancer Institute, again headed by Steve Rosenberg, they have a multi-million-dollar human experimental laboratory that is able to take T cells from individual patients and grow them to very large numbers and then infuse them back into people. And these are experiments that can't be done at every hospital in the world, and in fact can be rarely done. But by doing these types of experiments, they were able to show that a T cell from a cancer patient could be expanded and then infused back into a patient that had metastatic breast cancer. And the T cell response was sufficiently specific that it could completely eliminate all of the cancer cells in that individual patient. Now, again, this is a remarkable example, but what was exciting about it is that the toxicities were quite limited. As you can appreciate, the recognition of that specific social security number on the tumor cells allowed the therapy to eradicate the tumor and not really develop a lot of toxicities or side effects. Now, why doesn't this happen in everybody? Why don't our immune systems recognize our tumor cells and eradicate the tumor that exists in ourselves or our loved ones or our patients and so forth? And it turns out that the presence of these abnormal social security numbers by themselves is not sufficient to trigger an immune response. And it turns out that very sophisticated analysis over the past 2 decades has demonstrated that the presence of these antigens, these abnormal social security numbers, can trigger an immune response, but it's a much more efficient system if there are what we call co-stimulatory signals. Some people will call them danger signals that will trigger an immune response. In fact, this is the basis of vaccine therapies in which a COVID protein is mixed with these danger signals, and the body mounts an immune response against the COVID protein, leading to these apparently successful vaccines against the COVID virus. So the presence of the antigen just by itself is important and is necessary, but it's not sufficient without these danger signals or co-stimulatory molecules. And this cartoon just shows an example of the presence of the antigen alone actually turns out to be not a good thing, because you actually tolerize your body to abnormal cells. And this is in fact how many people try to desensitize you to things. For example, if you're allergic to bees, you might be injected with a small amount of bee proteins every month for a period of a year, and that small exposure to that antigen in the absence of a danger signal actually desensitizes you. So quite important to have the danger signal to trigger an immune response. Now, again, we can imagine that the immune responses and the danger signals have been tried in breast cancer vaccines or other forms of immunotherapy for many years, but we still weren't seeing the kinds of exciting results that we would hope to use to treat our patients. And what we found, again, in probably the past 10 or 15 years, is that not only are immune responses dependent on stimulatory signals or danger signals to trigger them, but immune responses are actively shut down. And no one had really thought about this before. It's like if you started a campfire, the campfire would, sort of burn, and it would run out of logs, and then the fire would be extinguished. And many people thought that the immune system worked in a very similar fashion. You started the immune response would be mounted, you would eradicate all of the virus or the tumor, and then the immune response would not have any more things to kill, would just sort of wander off and stop responding. And it turns out that in contrast to that, the immune system is actually actively shut down. And again, this is an example of the immune response against the COVID virus, just because that's a timely example. And we see here that once the virus enters the body, many components of the immune response, in this example, many different types of antibodies are generated, and then the virus is eradicated and the immune response is extinguished. But as we now know, there are some individuals in which the immune response is not actively extinguished, and people can have cytokine storm or inflammation in the absence of the virus infection. And in fact, this can be a devastating consequence of COVID infection that could lead to pulmonary failure and death and so forth. So we know it's quite complex, and in certain cases, the active shutdown of the immune system doesn't occur and you can be quite ill. In the case of cancer, the cancers tend to actively shut the immune system down, as well as using the normal components of that. This is a press release for the Nobel Prize about 2 years ago, and it was awarded, in fact, for this discovery that the immune system negative regulation or immune checkpoints actually cause the immune system not to effectively eradicate tumor cells or other antigens. And the two individuals who jointly shared the Nobel Prize were Dr. Allison from MD Anderson, who described the CTLA-4 axis, which was involved in triggering the immune system. Even though you have a danger signal, he found that there was a immune checkpoint that would shut down the danger signal, and so you wouldn't have the type of quality immune response necessary to eradicate tumor until you could eliminate this immune checkpoint. And Dr. Hanjo, who is from the University of Kyoto, identified another type of immune effector, PD-1, which actually shuts down the killer T cells, the cytotoxic T cells, from engaging and killing tumor cells or other antigen carrying cells in the periphery. A cartoon that illustrates both of these immune checkpoints is shown here, and this is from a recent, not so recent now, review from Tony Rivas from UCLA. And on the left side, you see the example in which the priming phase, the immune system is being stimulated, the peptide MHC complex is presented, and inhibitory signals, CTLA4 are there, and antibodies can block this inhibitory signal, and this can lead to an improved immune response. And in fact, this was developed as a therapeutic. This was an anti-CTLA4 antibody that has been approved for use in melanoma, and it improves the immune response to melanoma, which has been effectively used for the past 5 or 6 years. Now, probably more relevant to today's discussion was the PD-1, PD-L1 axis that was discovered by Dr. Hanjo, in which the effector T cells, these are T cells that are circulating, they're recognizing tumor cell, they're going to kill tumor cells, but in fact, when they get to the tumor, they engage with the PD-L1, the receptor ligand for the PD-1 receptor, and in fact, this stops the T cell in its track, and it can kill the tumor cell, and the cancer cell and cells around the cancer cell all express this co-stimulatory ligand PD-L1 and prevent the T cells from killing the tumor. And anti-PD-L1 therapies really, I think, have revolutionized the cancer care because they have proven to be effective not only in the kind of unusual tumor called melanoma, a pigmented skin cancer, but in very, very common tumors such as lung cancer, kidney cancer, bladder cancer, head and neck cancer, some forms of colon cancer, and as you'll hear about, some forms of triple-negative breast cancer. Now, this sounds like a fantastic idea, and it's been heartwarming to see the role of immune checkpoint inhibitors be used in cancers such as lung cancer. As a matter of fact, the #1 frontline therapy for metastatic lung cancer is an immune checkpoint inhibitor, which is, again, an unbelievably different form of therapy than the chemotherapy doublets that were tested for the past 2 to 3 decades in lung cancer. So it really has dramatically altered the treatment of many types of cancers. But one of the questions that we have is, why don't all tumors respond to these immune checkpoint inhibitors? And why are there people that once they have immune checkpoint inhibition, their tumors still don't disappear? And the idea here is that, as we heard about earlier, T cells have to be present, and these effector T cells have to be ready to go in and kill the tumor cell. And if you don't have T cells present to kill the tumor cell, you can give a lot of immune checkpoint inhibitor, but it won't really help. It really is taking the brakes off, but if you don't have your vehicle or your killer T cell ready to kill your tumor, taking the brakes off doesn't really help you so much. And some people use this term called the cold tumor, in which the immune system is actually suppressed and there aren't these effector killer T cells that are present. And they contrast that to a hot tumor in which T cells and other cancer-killing cells, such as NK cells and perhaps some other forms of effector cells, are present, and their potent activity can be unleashed when the immune checkpoint is provided. So you can imagine that people want to understand why tumors are hot and why some tumors are cold, if you will, not physically hot or cold, but why are they immune inflamed or not immune inflamed? And one of the things that people had thought about was the high levels of mutations in certain cancers that could lead to these antigens being present. This cartoon on your left shows a very sophisticated analysis of the number of mutations in a variety of cancer types. And you can see the types of cancers that respond to immune checkpoint inhibition in a very robust fashion, such as melanoma or lung cancer, are shown on the right, and they have very high levels of mutations. Breast cancer is kind of on the lower half, although there is a wide spread of mutations. On the right side of your screen is, again, the correlation between the levels of mutations and the response rate to these immune checkpoint inhibitors. And you can see on the very upper right, there are cancers that have high levels of mutations, and they appear to be able to be responsive to immune checkpoint inhibition. And on your left, there are lower mutation rates and, in fact, the corresponding lower response rates to immune checkpoint inhibition. Now, correlations aren't really proving causation, and there may be other factors that are related to immune checkpoints in addition to the presence or absence of these antigens. For example, as we mentioned, the danger signals or the type of immune environment of the tumor, in addition to antigens, could be really critical. And here's an example, and I think you'll hear more about this from Dr. Hurvitz, in which immune checkpoint inhibition can be combined with chemotherapy, and this combination appears to improve the response to immune checkpoint inhibition. And is it possible that the cell death caused by chemotherapy contributes to these antigens and the danger signal necessary to mount an immune response? Another idea, again, very creative strategies, I think spearheaded by Silvia Formenti, a good friend of the NBCC and the chair of radiation oncology at the Cornell and the New York Hospital. Why not use radiotherapy to target the tumor and try to trigger immune responses? And in fact, she did an elegant study in lung cancer and showed that she dramatically improved anti-tumor responses in combining radiotherapy with immune checkpoint inhibition of certain lesions. So, again, a quite exciting concept being developed. And very interestingly, attempted to be replicated in breast cancer. However, these early results weren't quite as promising as those seen in lung cancer. So, as you can imagine, the idea that combinations of strategies, other types of immune checkpoints, there are dozens, if you will, other strategies to damage the tumors or to create a more inflamed environment are being attempted. In fact, many people estimate that there are over 2,500 different clinical trials that are ongoing in which various combinations are being tested. Here, there are a variety of things that are actually directly injected into the breast tumors themselves. And this is an attractive strategy because the toxicities associated with immune checkpoint inhibition are related to the exposure of your entire body to some of these immune checkpoints. And so some folks have argued that perhaps if we just create the inflamed tumor solely in the environment of the tumor, these toxicities could be diminished. And in fact, interleukin 12, other strategies to attract immune cells such as oncolytic viruses, other types of strategies such as vaccines to stimulate tumor-infiltrating lymphocytes or ultrasound or cryotherapy and so forth are all being tested. One example that you may see at the San Antonio meeting is a study headed by Melinda Telly at Stanford in which interleukin 12 therapy is being utilized in combination with immune checkpoint inhibition, as one example of the many creative strategies in which the combinations are being attempted in breast cancer. So, as you can see, the field is quite excited about the opportunity afforded by immunotherapy for breast cancer. It's based on incredibly solid science that has been developed over the past 3 to 4 decades, resulting in a variety of Nobel Prizes associated with understanding how peptides are recognized by the immune system, how co-stimulatory molecules are critical for stimulating an immune system, and most recently for an understanding of how the immune checkpoint blockade strategy can unleash the effector mechanisms that are so potent in eradicating tumor cells and finding ways to appropriately apply these to the patients that have advanced in metastatic breast cancer, or perhaps even earlier, not only in the triple negative disease, but hopefully addressing the fundamental need for women with HER2 and luminal B or endocrine receptor positive breast cancer. So thanks for taking the time to hear some of the perhaps some of the history and some of the foundational elements of immune checkpoint blockade. And let me turn it over to Sarah.
That was great. That was a really good primer, not to make a pun. Immune therapy, nerdy humor here. So what I'm going to do is kind of take you into the clinical trial evidence that we have to date relating to immune therapy approaches for breast cancer. And as Dr. Lyerly indicated, breast cancer is a little bit behind the times. We saw melanoma and lymphomas and lung cancers. We've got approvals of immune-based therapy in all of these different histologies, and breast cancer has not been seen as a very immune responsive tumor. And so the studies were done a little bit later. And so let's talk about what the evidence is, first of all, in the metastatic setting. So shown here on this is we have a number of clinical trials that actually were performed with immune-based therapy as single agents, so not in combination with chemo or radiation, as Dr. Lyerly was exploring, but just giving the PD-L1 or PD-1 antibody. This is one of those clinical trials looking at a PD-L1 targeted antibody, atezolizumab. 116 patients with metastatic triple-negative breast cancer were enrolled in this clinical trial. They were allowed to have either received no prior therapy in the metastatic setting or one prior line of therapy in the metastatic setting. And about a quarter of patients had their disease either shrink significantly or go away. So it wasn't a home run. With single agent chemotherapy or double agent chemotherapy in the metastatic setting, we will often see objective response rates of 30, 40, 50%. So this was a response with a non-chemo agent, but not a home run. There were adverse events that were experienced by patients on this study due to the immune system being upregulated. So things like fever or fatigue, infusion reactions, feeling tired, diarrhea, itching, those were experienced, and that's not uncommon with immune therapy. The Kaplan-Meier curve on the right side is showing you the overall survival for patients based on whether they had never received prior lines of therapy in the metastatic setting, so first line setting, and that's in the blue line, and then in the orange line are patients who are second line therapy or beyond. And as is expected, patients who are more heavily pretreated in the orange line have a lower overall survival. So this wasn't a comparative study, wasn't being compared to standard of care chemo, but did give us an idea of the activity level of atezolizumab as a single agent in metastatic triple-negative breast cancer. Now, this dizzying plot here is making the point that only the minority of patients actually benefit from immune therapy as a single agent. On the left side is a curve from a study, single agent study of atezolizumab. On the right side is a study looking at single agent pembrolizumab, which is an anti-PD-1 antibody. Each one of the little hair-like lines, it represents one patient and their disease path. And on the y-axis, you can see that from the change from baseline in the tumor growth. So if a patient's little curve goes above the 0 point, that means their tumor is growing. If it goes down below, -20, -40, the tumor is shrinking. So you see some patients are having tumor shrinkage, and some patients, the length of the line tells you how long they were on treatment. So some patients, we've got one patient on atezolizumab who went out 840 days. Similarly, there are longer survivors with pembrolizumab as well, but it's the minority of patients have this durable response. So how do we figure out who's likely to have a tumor that is very responsive to immune therapy and distinguish those patients from those who are likely to be resistant or need a little bit more help to get control of the tumor. One of those features may be the level of expression of PD-L1 on the tumor immune cells or on the tumor. In this analysis here, looking again at a trial where everybody got just atezolizumab, single agent immune therapy in the metastatic setting, it was shown that there was a higher chance that there would be an objective response, the tumor shrinkage or disappearance, and a longer overall survival in those patients whose tumor immune cells had PD-L1 expression, defined as at least 1% of the cells in the tumor immune microenvironment, the immune cells having expression of PD-L1, compared to those with less than 1%. Higher levels of immune cells also was independently associated with better outcomes. So there's two clues there, that if you have immune cells, a lot of immune cells, or immune cell PD-L1 expression, you're more likely to respond or have a better outcome with single agent atezolizumab. Also, tumor infiltrating lymphocytes in the stroma, known as STILS, has been associated with response to single agent pembrolizumab. On the far left is cohort A. These are patients who were treated and they had had at least one prior line of therapy in the metastatic setting, maybe even more, so more heavily pretreated patients. Cohort B are patients who had never received treatment for metastatic triple-negative breast cancer. They're more likely to respond to therapy. And then on the far right is the outcomes of those two cohorts combined together. The blue indicates those patients who had stromal tumor immune cells greater than or equal to 5% in the tumor immune microenvironment. And these patients were the ones that had a better chance of having an objective response. So this is a summary here. We know there are a few things that predict the likelihood of a patient having a tumor response to immune therapy as a single agent. First of all, PD-L1 expression with atezolizumab. Second of all, more immune cells in the microenvironment, and also less heavily pretreated disease. As shown here, the objective response rate associated with either single agent atezolizumab or single agent pembrolizumab is higher for patients who are in the first line of therapy. So their immune system has not been beat up by sequential rounds of chemotherapy. We know that as patients have received more and more lines of therapy, the chance of having a response to any type of therapy, not just immune therapy, is lower, and that's shown here. Now, Dr. Lyerly talked a little bit about combination strategies. Are there ways that we can turn a cold tumor into a hot tumor, an immune non-responsive tumor microenvironment into an immune responsive tumor microenvironment? And we know from studies that were done in the neoadjuvant setting, so patients have an intact breast tumor, their first diagnosis, they have a baseline biopsy, they get some chemotherapy, and they have a second biopsy, so post-NACT is post-neoadjuvant chemo. You can see the tumor immune lymphocytes either in the intratumoral area on the left side or in the stroma, that surrounding area on the right side there, increases. So you see sort of like the immune cells are being called in by chemotherapy and making that immune microenvironment and the tumor microenvironment more amenable to immune-based therapy. And in fact, we know from a number of other different clinical trials that these different agents shown here at the bottom may be able to improve the immune responsiveness of a tumor by suppressing the regulatory immune cells, down-regulating those cells that are going to turn off the immune response, and bringing in immune lymphocytes into the tumor microenvironment. So based on this, there have been a number of clinical trials designed where immune-based therapy is combined with single-agent combined with single agent or double agent chemotherapy. So for example, the first study that had a positive finding was the Impassion 130 clinical trial in the metastatic setting. Dr. Lyerly showed you the summary of the results of this trial at the end of his talk. And in this study, patients who had never been treated for metastatic triple-negative breast cancer and were pretty healthy were enrolled on this clinical trial and randomly assigned to receive either atezolizumab or placebo, both in combination with nab-paclitaxel. Now, nab-paclitaxel is a chemotherapy that does not need to be given with steroids, with dexamethasone, because it's albumin-coated, so infusion reactions and allergic reactions are unlikely with this agent. So you're not giving steroids to dampen an immune response, and you're combining it with an immune-based therapy. In this trial, there were co-primary endpoints of progression-free survival as well as overall survival, that's shown here, in both the intent to treat and the PD-L1 positive populations. Now, it's a bit of an interesting clinical design that study design that I'm going to take you through here. The way that the statistics was set up in this study, the progression-free survival had to be demonstrated in the intent to treat population, meaning the whole population of patients first, and then you could go on and test it if its PFS is better in the PD-L1 positive population. So on the left Kaplan-Meier curve here, you can see that the median progression-free survival for patients getting atezolizumab was 7.2 months, which was almost 2 months longer than those patients getting the placebo combined with nab-paclitaxel. Now, it's kind of a modest benefit, but it did meet the pre-specified statistical significance. The p-value is 0.0025. So then they were allowed to go on and statistically test if the PFS was better in those patients whose tumor immune cells were PD-L1 positive. Indeed, these are the patients who do appear to be getting all of the benefit. The PFS is 7.5 months with atezo and only 5 months with placebo. So a 2.5-month improvement, and the hazard ratio was 0.62, which is better than in the intent to treat population, and the p-value less than 0.001. So they met those two primary endpoints and were allowed to go now as the second step and look at overall survival in the intent to treat population. If that is statistically significant, they're allowed to then statistically test if overall survival is better in the PD-L1 positive population. Here are those results. So on the left side is the overall survival in the intent to treat population. It is not positive. There is no benefit with the atezolizumab in all patients combined together, PD-L1 negative, PD-L1 positive. However, they went on and as an exploratory analysis without formally testing for a p-value, they showed that in the PD-L1 positive population, there was about a 10-month improvement in overall survival in those patients whose tumor immune cells were PD-L1 positive. So they got very excited about this. Based on these results, the FDA did approve atezolizumab in this setting in combination with nab-paclitaxel, but only for patients whose tumor immune cells were PD-L1 positive by the SP142 antibody. A little bit controversial because they didn't show it in the intent to treat population, but the FDA was likely compelled by that 10-month improvement in overall survival in that patient population and allowed the approval to go through. Adverse events were increased by adding immune therapy, and as you'd expect, autoimmune phenomena are not uncommon when you're ramping up the immune system. More fevers, infusion reactions, hypothyroidism, so thyroid disorders occur in around 15% of patients. So patients on immune therapy have to have their thyroid function followed and need to be followed for other serious immune reactions that can occur. Now, questions come up is this testing strategy for PD-L1 is become quite confusing for clinicians and patients alike. Clinicians, often medical oncologists are treating lung cancer and breast cancer and ovarian cancer. They're doing all types of cancers, and we have different tests that are have been approved for other immune therapies, and now they come along and approve atezolizumab, and it's only approved if the tumor immune cell is PD-L1 positive by this SP142 antibody. So if you've tested it with a different antibody strategy, you have to retest it. It's kind of a pain. But what this is showing you here is that if you test the tumor immune cells, so the right side of the picture here, 41% are going to be PD-L1 immune cell positive, and that captures tumor cell PD-L1 positivity. It's important, I think, to make sure that we're specifying to test the tumor immune cell, not the tumor cell, because it's uncommon that the tumor cells themselves express PD-L1. In fact, I saw when atezo was first approved, a number of patients who came to me and they said, I'm PD-L1 negative, so I can't use atezo. And they were tested for the tumor cell, not the tumor immune cell. When we retested for the tumor immune cell, they were indeed positive. It's also important to note that the percentage of PD-L1 positivity is higher depending on which area, where you're getting the tumor from. For example, the breast has the highest rate, liver has a relatively low rate. So if you're testing for tumor immune cells, you actually want to go with the area that has the highest chance of expressing it. Impassion 131 came along, and this kind of shocked and shook the immune therapy world for breast cancer treatment, because this was a flat negative study. In this study, very similarly designed to the study I just showed you, Impassion 130, they combined paclitaxel, not nab-paclitaxel, with the atezolizumab. Again, a very similarly designed study, but remember, with paclitaxel, you have to give dexamethasone or steroids to mitigate the allergic reaction to paclitaxel. And that may be why we saw zero benefit. Even in the PD-L1 positive population, there was no statistically significant improvement by adding atezolizumab to paclitaxel. So if we're going to use atezolizumab, it needs to be with nab-paclitaxel. Keynote 119 was a clinical trial that initially looked at pembrolizumab, the PD-1 antibody, head-to-head against single-agent chemotherapy in metastatic triple-negative breast cancer. And the way they studied the PD-L1 expression in this study was using something called the Combined Positive Score, or CPS, where they test the number of PD-L1 stained cells, tumor cells, lymphocytes, and macrophages. So the tumor cells and the tumor immune cells. They divide that by the total number of viable tumor cells and then multiply by 100. And you get a score, 10 or greater, 1 or greater, or 20 or greater, and you can look at whether pembro is benefiting patients based on their CPS score. And it's being tested by an antibody called the C22C3, which is different from the SP142. See how confusing this is? So anyway, in the left upper corner here, you can see the intent to treat analysis. There's no difference between single agent pembrolizumab and single agent chemo. Maybe a trend towards slightly better outcomes with chemo, but really very indiscernible difference. There was really no difference. And then if you look on the right upper corner, looking at those patients whose CPS score was 1 or greater, you're seeing, again, no difference between pembro and chemo. And in the left lower corner, if their CPS score is 10 or greater, really no difference, although we're starting to maybe see maybe an improvement in overall survival by about a month, but it's not statistically significant. And then when you get those patients who's got lots of PD-L1 expression in the tumor area, CPS 20 or greater, now we're seeing more than a 2-month improvement in progression-free survival or overall survival with the use of pembrolizumab versus chemo. So this set the stage for this clinical trial, the Keynote 355 study, in which pembrolizumab was combined with chemo. So patients got pembro with chemo or placebo with chemo, but what's different from the Impassion 130 study is they allowed patients to receive either nab-paclitaxel or paclitaxel or gemcitabine carboplatin in this trial. Now, gemcitabine carboplatin has the advantage of no hair loss and being a little better tolerated in terms of neuropathy than the taxanes, also doesn't require steroids, and more than 50% of the patients in this trial did decide to receive gem carbo as their chemo of choice. And here are the results. The progression-free survival in the intent to treat population is shown on the right. There was about a 2-month improvement associated with pembrolizumab, and the hazard ratio was 0.82. But if you look on the left, in those patients whose CPS score was 10 or greater, you see this statistically significant improvement in PFS associated with the use of pembrolizumab. At San Antonio this week, there will be updated results. I think Hope Rugo will be presenting of this study looking at the outcomes based on which chemo partner they chose to take. Based on this, pembrolizumab was FDA approved November 13th, just less than a month ago now, for patients whose tumors express PD-L1 based on the CPS scoring system, so the 22C3 PharmDex test. So we now have 2 approvals, atezolizumab, which is given every 2 weeks IV in combination only with nab-paclitaxel weekly. And the test to test whether or not you're appropriate for that is the SP142 assay of the tumor immune cells, and then pembrolizumab, which is given every 3 weeks prior to chemo in combination with one of those chemo regimens shown there in patients whose tumors express PD-L1. Now, in the last few minutes of my talk, we'll go over neoadjuvant clinical trials, so studies of immune therapy in the curative setting prior to surgery. So the first of these that we'll go over is the Michelangelo clinical trial, or the NeoTrip trial. In this trial, atezolizumab is being evaluated in combination with carboplatin plus nab-paclitaxel. Patients received 8 cycles of this regimen. It was a non-placebo controlled trial, so patients knew what treatment arm they were in, and they did not receive any anthracycline-based therapy prior to surgery. So all of their treatment done before surgery was the taxane and the platinum therapy. Their primary endpoint was event-free survival at 5 years after randomization of the last patient. So their primary endpoint was not powered for pathologic complete response rate, and that's the only data we have to date is pathologic complete response rate in the breast and lymph nodes. So here are the results in terms of pathologic complete response. Look to the far left, just those are those 2 columns there. Blue is atezolizumab, red is just chemo alone. You can see there's no improvement, significant improvement in the rate of path CR by adding atezolizumab to chemo in the overall population. And then the subsequent groupings are based on PD-L1 expression. So PD-L1 positive, there's maybe a 3.5% better path CR rate, not statistically different. PD-L1 negative, no difference whatsoever. Early high-risk patients, maybe a trend, but not statistically significant, and locally advanced. There was no subgroup that they could define where atezolizumab improved the rate of path CR at the time of surgery. There were higher rates of adverse events related to immune therapy, but the most important, really, the red is moderate to severe adverse events or toxicity. So the one that needs to be watched for here was abnormal liver enzymes. The rest of the toxicity is fairly well balanced when you look at the 2 treatment arms. Then Impassion 031 came along. This was presented at ESMO just a few months ago. This was a phase 3 clinical trial that looked at atezolizumab combined with nab-paclitaxel, followed by atezolizumab plus AC, so adriamycin cyclophosphamide. So in contrast to the NeoTrip trial I just showed you, where patients got taxane and platinum before surgery, In this study, there's no platinum use, and everybody gets the anthracycline. This was a placebo-controlled trial as well, and the co-primary endpoints were to look at path-CR in both the intent to treat and the PD-L1 positive subpopulation. This is not a study that is powered to look at event-free survival and long-term outcomes, and it's a larger study than the NeoTrip trial. And here are the results. There was a significant increase in the rate of path-CR by adding atezolizumab to chemo. You can see a 16.5% improvement. So on the far left is the path-CR rates in the overall population. In the middle there are the patients with PD-L1 positive breast cancer, statistically significant improvement of almost 20%. And on the far right is the PD-L1 negative. There is not a statistically significant improvement in path-CR in the PD-L1 negative, although numerically there's a slightly better path-CR rate. So these data are in contrast to NeoTrip that I just showed you. Here we're seeing atezolizumab does improve path-CR rates and does appear to be pretty restricted or fairly restricted to PD-L1 positive disease. Why are you seeing one study that's negative and one that's positive? And there's a few theories. Some people believe that perhaps it was the use of the anthracycline cyclophosphamide chemo, and that cyclophosphamide may help that immune microenvironment be primed for breast cancer responsiveness to immune therapy. Here is another study looking in the neoadjuvant setting called the I-SPY clinical trial. This is an adaptive randomization strategy, so small arms, and they essentially are trying to test different types of treatment strategies for patients and get an idea of what the path-CR rate might look like using what's called Bayesian statistics. So they predict how likely it is that a given regimen will be positive in a larger clinical trial. It's a very interesting trial design. So in this particular two arms, they're comparing paclitaxel to paclitaxel plus pembrolizumab, followed by AC chemotherapy, and then surgery. And here you can see they enrolled not just triple negative, but triple negative, HER2 negative, and hormone receptor positive HER2 negative. And you can see that the probability that pembro is superior to control is quite high, actually, for all of these subsets, especially triple negative and HER2 negative. So this gives us some insights that pembrolizumab might be effective in the neoadjuvant setting. Of course, thyroid toxicity was fairly common, as we discussed earlier. You can see this occur with immune therapy. And then another study called Keynote 173 looked at neoadjuvant pembrolizumab with chemo. Cohort A was just giving nab-paclitaxel with pembro followed by AC. Cohorts B through F are giving nab-paclitaxel plus carboplatin, and the difference between B, C, D, E, and F is just in the dosing and frequency of the nab-paclitaxel and carboplatin. It's not really different. You can kind of combine B through F. And then everybody gets the adriamycin Cytoxan after the taxane-based therapy. All cohorts in this study received pembrolizumab. And what this shows you here on the left is the objective response rate. So not pathologic complete response rates, but the objective response rate, the percentage of patients who have a partial response or complete response. Complete response is in green, partial response is in purple. And on the left, it's after they got the taxane or taxane platinum. And you can see, there's some patients, 20 to 40% have a complete response after regimen 1. But after regimen 2, where you give it with the anthracycline and Cytoxan, you're seeing a much higher chance of an objective response. Now we're getting to close to 100% in some of those cohorts, with complete responses seen north of 40% for most of the cohorts. So this speaks to that theory I brought up of why atezolizumab may look better in the Impassion 031 study compared to the NeoTrip study. Maybe we need to give a different type of chemo, this AC chemo with immune-based therapy in the neoadjuvant setting to give it the best chance of working. Another theory would be maybe we just need time. Maybe over time you're going to accrue more objective responses because it takes time to mount the immune response. Now, a more definitive randomized trial called Keynote 522 was presented at ASCO in June of this year. In this trial, patients received carboplatin paclitaxel followed by anthracycline plus cyclophosphamide, and then 2/3 of patients received pembrolizumab, 1/3 received placebo, and then patients went to surgery. And here you can see that the pathologic complete response rate in the entire population, intent to treat population, was about 13.5% better with pembrolizumab. And then breaking it down based on the right side, whether the tumors are PD-L1 positive or PD-L1 negative, you're still seeing a benefit in PD-L1 positive and in PD-L1 negative tumors, although the PD-L1 positive group does appear to have a statistically significant improved path-CR rate, and it crosses the null point in the PD-L1 negative. So these data are kind of interesting, but of course we're waiting to see event-free survival outcomes associated with this. Again, infusion reactions are more common with immune therapy, thyroid disorder, rashes, adrenal insufficiency. These sorts of things can occur by adding immune therapy. Weird things can happen with immune therapy. You can have an autoimmune response literally anywhere in your body with immune-based therapy. And so it's important when we're looking at these data in the curative setting that we take very seriously the side effect profile because a patient may be cured just by the surgery and chemotherapy. We don't know how many are going to benefit by adding the immune therapy. And so we really do need long-term data in terms of recurrence rates and survival before, in my opinion, widely adopting these therapies. And then finally, another interesting study that was presented last year is the JEPAR Nuevo clinical trial. And the reason this study is interesting is they have this interesting 2-week run-in where patients receive single agent durvalumab, again, immune therapy, or placebo. And then they get a biopsy, and then they go on and receive their nab-paclitaxel with immune therapy or placebo, and then their anthracycline-based therapy, and then they go to surgery, and patients are getting biopsies done sequentially throughout each of these stages. The reasons it's interesting is there is this concept that maybe you should prime the tumor with the immune therapy by giving immune therapy first before we bring in the chemo. And in fact, in this study, there was no significant difference in path-CR rates by giving patients the durvalumab with the chemotherapy. However, if you break it down based on patients who got the window treatment versus no window treatment, the patients who got that first dose of durvalumab as a single agent without chemo, they had about a 20% better path-CR rate compared to placebo. In contrast, those patients who just went straight into receiving chemo actually did not benefit from the addition of durvalumab. So it's just hypothesis generating and something interesting to think about as new studies are being designed. And then again, thyroid disorder, most common immune-related adverse event. So that was a lot of clinical trials that I tried to review in not too great detail, but to give you the broad strokes. In summary, immune checkpoint inhibitors show, I would say, modest activity as single agents in metastatic triple-negative breast cancer, usually around 20%, which interestingly is in the range that Dr. Lyerly predicted based on the tumor mutational burden in breast cancers. And the benefit is very limited in the later line setting. The responses typically are happening in the earlier, less pretreated setting. Combination with chemotherapy is very promising, but it does appear to be restricted to those tumors and tumor microenvironment with PD-L1 expression. And we have not seen in any of these studies yet a statistically significant overall survival in the pre-specified analysis. There's interesting survival signal in Impassion 130, but that wasn't technically allowed to be tested based on the rules that the study was designed with. We do have 2 FDA-approved agents in the metastatic setting. Right now, we don't have any FDA-approved agents in the neoadjuvant or adjuvant setting, and use of those agents would be outside of guidelines at this point. And toxicity is something that we especially need to consider in the curative setting, where patients may be cured by regimens and interventions that have known safety profiles and known long-term outcomes. So with that, I will close, and I think I've seen some questions come through as well. Thank you.
Thank you, Dr. Hurvitz. Next, we'd like to have Michele Atlan, who will share an advocate's perspective. Michele?
Thank you, Ibis. Preventing access to a potentially life-saving drug can seem very cruel, especially to patients living with metastatic disease. It's tempting to accept the risk of a new experimental drug if there's even a small chance that it may be beneficial. But the truth is, we've established regulations about how drugs are approved to protect us all, and these vulnerable patients must be safeguarded. The National Breast Cancer Coalition believes there should be no shortcuts when it comes to ensuring the safety and efficacy of breast cancer treatments. Unfortunately, the pharmaceutical companies and the FDA sometimes play by rules that can be inconsistent, specifically when it comes to accelerated approval. So how should the FDA's accelerated approval process for drugs work, in particular as it pertains to the issues raised in the Impassion trials that Dr. Hurvitz described? For new treatments to be approved, they must be shown to demonstrate a clinical benefit. Concretely, this means the drug should have a favorable effect on a patient's symptoms, functions, or survival. For cancer patients, it should improve their quality of life or prolong their life, and preferably both. However, it can take an extended period of time to prove that a treatment confers clinical benefits, especially in terms of overall survival. Because of this, in 1992, the FDA introduced regulations to authorize accelerated approval of drugs for serious conditions with unmet medical needs. In order to expedite this conditional approval, clinical trials can use surrogate endpoints that are considered likely predictors of clinical benefit. In other words, these surrogate endpoints do not directly measure how a patient feels, functions, or survives, but are hopefully good intermediate indicators of drug effectiveness, such as progression-free survival, for example. Unfortunately, however, surrogate endpoints do not always correlate to how well a treatment works, and there can even be study outcomes that are false positives, creating dangerous precedents. For these reasons, even if a drug receives accelerated approval from the FDA, the guidelines state that the pharmaceutical company will still need subsequent studies to confirm that the drug really does improve and/or extend the patient's life. These studies are called Phase 4 confirmatory trials, and it would make sense that if a drug receives accelerated approval but fails to show clinical benefit in these follow-up trials, the FDA should automatically withdraw the approval of the drug for that specific use or population. This is how the process should work, but is it really how it does work? A 2019 study published in the JAMA Internal Medicine Journal looked at 93 cancer drugs that received accelerated approval between 1992 and 2017. Of these 93 drugs, 19 showed improved overall survival. However, only 5 of the 93 drugs have since been removed from the market. Furthermore, almost half of the approved drugs had confirmatory trials that were delayed or pending, and of those that were completed, many continued to use surrogate endpoints rather than overall survival as so-called proof of clinical benefit. Approving a medication with scant or no proof of clinical benefit can be detrimental for many reasons. For example, patients may be encouraged by trial results for a drug showing an increase in progression-free survival, particularly in the metastatic setting. However, if their lifespan will not be extended at all, and the remaining time they have left consists of dealing with often debilitating adverse side effects, as well as the financial burden of these incredibly expensive new drugs, is there truly any advantage for them? This brings us back to the subject of atezolizumab and the IMpassion trials. Why must we be vigilant looking at the results of the original IMpassion 130 trial and the initial data from the confirmatory IMpassion 131 trial? In IMpassion 130, atezolizumab was combined with one form of chemotherapy, nab-paclitaxel, whereas the confirmatory trial combined it with another form, paclitaxel. Dr. Hurvitz explained this to us. But that is already one indication that the follow-up cannot be seen as confirming the previous data. Next, and as Dr. Hurvitz also explained, in the original trial, the drug did not improve overall survival in the larger study population. As a result, the investigators were unable to assess statistically whether or not the drug worked in PD-L1 positive patients because it would violate their statistical protocol. While the results looked favorable in the PD-L1 positive subgroup, we can't be sure that this was not a type 1 or false positive error. So IMpassion 131 not only used a different chemotherapy from IMpassion 130, it also included the subgroup that had not seen overall survival benefit in the original trial. And its primary endpoint remained progression-free survival, not overall survival. Worst of all, the confirmatory trial showed not only a lack of progression-free survival in either of the subgroups, but it actually showed a trend towards having a negative effect on overall survival benefit, even in the PD-L1 positive patients. To be clear, this means that atezolizumab combined with paclitaxel may actually reduce overall survival. Whether these results are due to the change in chemotherapy or whether the original trial had false positive results, the fact is that there remains scant evidence of efficacy or safety for the use of atezolizumab in metastatic triple-negative patients. Even if the results of IMpassion 131 were less negative, one confirmatory trial cannot be considered adequate enough for proof of approval. Furthermore, the FDA's rules of accelerated approval do not even mandate an automatic withdrawal upon the verification of negative confirmatory results. One must ask oneself who benefits from the arrival on the market of unproven, expensive drugs. I think the answer is clear. The National Breast Cancer Coalition has distributed a press release calling on the FDA to withdraw approval for atezolizumab in this particular setting until clear evidence of clinical benefit can be demonstrated. In the meantime, dozens of checkpoint inhibitor trials continue to be conducted as immunotherapy has become an increasingly established pillar of cancer treatment. Hence, it is so important that clinical trials be carefully designed and monitored so that advancement in the field is based on the most solid and promising data. Just last month, the FDA granted another accelerated approval for a different immune checkpoint inhibitor, pembrolizumab or Keytruda, as we've heard, for patients with advanced and metastatic triple-negative breast cancer whose tumors have a 10% or greater PD-L1 expression. This is compared with the lower cutoff point of 1% required for use of the atezolizumab and uses a different diagnostic test to establish the percentage. Keytruda's accelerated approval is based on the Keynote 355 trial, and as the FDA label shows, it can be combined with one of several standard chemotherapies, including paclitaxel, unlike atezolizumab. However, there remain many questions. What level of PD-L1 positivity should patients express? And is it different for different checkpoint inhibitors? What test is the best test to determine someone's PD-L1 positivity? And which chemotherapeutic agents should each checkpoint inhibitor be combined with? Do any of these drugs actually improve overall survival? Why do we include populations who have shown no response in future trials for the same drug. Questions like these bring us to the bigger picture of what influence we as advocates can have on the development of breast cancer trials. Without brave cancer patients willing to participate in studies with unpredictable outcomes, these studies could not exist. Therefore, it's essential to make sure that the research actually has a chance of making a difference in clinical practice. Which of the many clinical trials being conducted actually warrant patient participation? We need to be able to identify those trials and work to help make them a success. Our input on trial design or reporting requirements for results could be invaluable. Reporting negative trial results is just as essential as announcing positive ones, and we respect researchers and companies that have shown this transparency. However, unless adjustments are made taking the unvarnished results into account, including abandoning any failed hypotheses, patients' bodies and lives may be sacrificed for nothing. As NBCC patient advocates, it's our duty to speak up so that drug companies are pressured into putting the well-being of breast cancer patients first. As I mentioned before, patients living through the fear and stress of metastatic disease can be desperate for quote-unquote miracle cures, which is totally understandable. However, being granted access to a treatment that could debilitate, bankrupt, even kill them is not an acceptable solution. Thank you.
Thank you, Michelle. I want to thank everyone for their wonderful presentations, and now I'd like to bring all of our speakers back to discuss what we know and what is next for immune checkpoint inhibitors. I've also noticed that we do not have a lot of time, so I'm going to ask you to keep your responses short. This is quite interesting, so I'm very thankful. Got quite a few questions, not just listed in the chat space, but also some that had been sent to us previously. So I'll do a quick rundown. One of the questions we'll start is, can you give us your perspectives on thinking about what is really known about immune checkpoint inhibitors, and also how the current trials are adequately designed? Do you think immunotherapy trials should be designed differently? Do we need a paradigm shift?
That's quite a question. I think somebody asked for my slides, so I think my slides and presentation actually addresses most of that question. And I think that Michelle's summary of trial design should be taken into consideration. Michelle's talk, which included discussion of trial design, should really be taken into consideration, and there are some very important points. I completely agreed with your talk, Michelle, and I think, we have to, look at the gold standard and prospectively design studies the right way and then interpret them fairly. So I think that there are still a ton of questions left to be answered relating to immune therapy. There are some very novel studies that are ongoing, looking at different combinations, as Dr. Lyerly said, in combination with radiation and other types of therapy. Also, multiple different immune therapies being utilized together. Again, I think we have a ton to learn. We're really behind here, and so we're going to need a lot more evidence before this is something that I jump up and down about being excited. Just to put it in perspective, this isn't like the HER2 story. We've got more of an uphill battle here in learning how to appropriately utilize these agents for breast cancer. Maybe Dr. Lyerly or Michelle wants to add to that.
Well, this is Kim. I think the idea that immune therapy is going to be effective in the same way for all tumor types is something that I think people are appreciating is not necessarily true, and it allows us to think about the different types of tissues that are involved in cancer. For example, the lung and the skin and the bladder, all are sort of defense types of tissues. Your sort of body is defending against lung infections and skin infections and urinary tract infections. And, you can find an immune checkpoint inhibitor that leads to benefit in those types of tumors. In contrast, breast cancers and prostate cancers are in organs in which proteins from the body are actually transferred to other individuals, like milk or seminal fluid or prostatic secretions in sperm and so forth. And one question is whether our understanding of the immune checkpoints in these organs are identical to other types of organs. And there may be fundamental differences that we have yet uncovered. So I think the fact that there are some suggestions that the broad class of immunotherapies is beneficial in life-changing and increasing survival from some of the more challenging cancers is a sign of the potential. But I agree that the utility of them and the specific utility of the existing immune checkpoint inhibitors should be rigorously tested. And again, the novel strategies like PATH-CR, Sarah's so young that she doesn't remember that used to be a really controversial endpoint and perhaps not really seen as useful. And my hope there would be some alternative strategies, perhaps liquid biopsies and circulating tumor DNA will be another signal that illustrates the anti-tumor effect of the many combinations, and perhaps down selection and prioritization of those most promising strategies will be enabled by some of these new technologies.
Michele, is there anything you'd like to add to that?
No, I don't have any scientific background to add to that, but
okay. So due to the time, I'm going to ask just a few of these, but a lot of the questions that were coming up were again with respect to the testing and should we continue to include patients in clinical trials who do not express PD-L1, and if so, why? Anyone?
Well, that's a point of contention, that I actually struggle with. I'm on steering committees of trials, and I really don't think we should be, at least with atezolizumab, doing wide use of this agent in clinical trials in PD-L1 negative tumors. We've seen fairly convincing evidence that it's not really benefiting patients. So. But I think it's going to have to be a case-by-case situation. And if you're looking at atezolizumab in combination with another therapy that may target the immune system, it's possible that the benefits will expand beyond PD-L1 positive. So it depends how strong the biological rationale is, I think. I think we have to think carefully about this, and I'm always encouraging our industry partners to include advocates on our steering committees to help us think through these kinds of questions.
Anyone else? So then I'll go on to the third question. What do you think are the most appropriate endpoints for immune checkpoint inhibitors in breast cancer? We've heard from a number of sources that progression-free survival, which is commonly used, may not be an adequate endpoint for immunotherapy trials. What do you all think?
Do you want to go, Dr. Lyerly, first, Kim?
Well, again, I think these are terrific questions, and I think they represent a sequence of endpoints that help provide some guidance for further testing. And I think Michelle's really beautiful summary of the approval process and the utilization of process. As you know, the European system is slightly different. They don't grant accelerated approval. They grant conditional approval. And every year, the sponsor has to provide compelling evidence to maintain that conditional approval until there's proven benefit, survival benefit, or some objective clinical benefit to the patient. Alternatively, in the U.S., the accelerated approval can be withdrawn, but for example, up until the anti-angiogenesis agents were withdrawn after accelerated approval, that was a relatively infrequent event. So I do think there's a balancing act. One is, I believe that clinical benefit to the individual patient has to be the gold standard, but I also know that it may take some time and effort to achieve that level of evidence, and the balancing act is always going to be in an investigative and an exploratory mode. What is the right balance of support to prioritize additional studies versus discarding ideas that perhaps may be useful. Again, if we don't have the right trial design, we pick the wrong patient population, and we reject agents that are potentially beneficial to individuals, balancing the idea that we approve products that are beneficial and potentially toxic, certainly that's a poor outcome. So I know that Sarah has probably a very thoughtful and probably more informed perspective on it, so I'll toss it back over to her.
No, I think overall survival is our gold standard. In diseases like HER2-positive breast cancer and ER-positive breast cancer, it's a really tough endpoint to meet. So we have to use surrogate endpoints to give us an idea the level of activity of a drug. And if a drug is substantially improving progression-free survival and quality of life is maintained or improved, but there hasn't been overall survival benefit demonstrated because patients live so long with a particular type of breast cancer, so you're not going to impact overall survival unless you follow 10 years. I think there's a role for PFS in that type of tumor subtype. In contrast, triple-negative breast cancer, you can see the overall survival endpoint pretty quickly. If you just look at the ASCENT study of sacituzumab govitecan, these patients with triple-negative metastatic breast cancer, many of them will have very, very aggressive disease. So we should be holding feet to the fire to demonstrate an improvement in overall survival, especially when there are toxicities that can be very, very significant, life-threatening. When I'm on the inpatient oncology service, it's not uncommon to have 5 patients on the wards with autoimmune-related colitis, pneumonitis, adrenal insufficiency. It's not something to, blow off. And so I do think we have to take that into consideration and also make sure that our endpoints include quality of life metrics.
Exactly. I just wanted to double down on that if progression-free survival, which could be considered valuable to specific patients, is accompanied by quality of life, then there's no reason not to see that as something valuable. But if it's accompanied by, a quality of life that's really diminished, once again, we have to see if that a true advantage or not.
Thank you. So I have the time for one last question. What other immune-based therapies are on the horizon, excluding CAR-T types of therapies? Are other immune cell types being examined as potential targets for therapy?
Well, I'll mention, and I'll let Sarah and Michele also comment. We focused a lot on the T cell, and that's been a prominent player. And as I point out, antibodies had been used in the past, but obviously B cells, and there's a form of cell called NK cells, which are innate killers, and also macrophage and other types of phagocytic cells that also have immune checkpoints. These are called, oddly enough, the don't eat me signals, and they're sort of in an axis called CD47 and the SIRP1 alpha. And these actually can work in concert with antibodies. In fact, if you block the don't eat me signal, you actually can enhance the effectiveness of Herceptin-based therapies, and this may enable even some attractive antibody-based targeting for tumors. I think the emerging role of antibody recognition of other antigens on tumors is really remarkable, and so I do think the explosion in opportunities is, to me, very exciting, and again, really points to the fact that it really is an opportunity for the scientific and medical community to partner with the advocacy community to rationally and thoughtfully prioritize studying these opportunities.
Yeah, I really don't have anything to add to that. I'm kind of excited about the NK cell therapies and the possibility that that'll mitigate the toxicity that we see and from CAR T type therapies. So, but no, I think Kim's reviewed it.
And I just wanted to say that's why I believe that NBCC is so valuable, because we have programs like Project LEAD that trains patient advocates to be able to understand enough of the science to really be able to give input that can make a difference.
Thank you. And just through another one, a quick one. Which is the most appropriate way to test for PD-L1?
Well, you now have 2 accelerated approvals with 2 different tests. So that's a big question. And at some point, it becomes kind of silly to be doing all these tests. So the 22C3 assay, which has been used, I think, for lung cancer and other cancers as well. A lot of institutions can do it on the tumor quite easily. Combines the PD-L1 positive cells, both the tumor and the tumor immune cells, so it kind of captures everything, and is the test that is supported as a companion diagnostic for pembrolizumab use in triple-negative breast cancer. The atezolizumab use, the insurance companies may require that the tumor immune cells be tested by SP142 in order to use that. So if that's the agent that the oncologist and patient choose to move forward with nab-paclitaxel, then you would have to test the tumor immune cells using that assay.
Okay, thank you. So on behalf of NBCC, I want to thank Dr. Lyerly, Dr. Hurvitz, and Michele Atlan for their time, expertise, and presentations today. I also want to thank the Alamo Breast Cancer Foundation for their support and assistance in coordinating this event. And last but not least, thank you to all of you who joined us around such thought-provoking topics. And once again, we're constantly learning. We want to thank everyone for becoming involved and learning more about who NBCC is and what research is out there and what we as patient advocates can do to help things move forward. Thank you and have a wonderful evening.
Thank you. Bye-bye.
Thanks, everyone.